Imagine taking a 3.5-inch needle to your most sensitive internal anatomy right in the middle of your lunch break.
Oh, wow. Yeah, that is an intense image.
Right. And dropping nearly $2,000 and then just going right back to the office an hour later.
Just a totally normal Tuesday.
Exactly. And you are doing all of this because, well, a high-end clinic promised you that this single quick injection would just instantly save your sex life.
Which is such a wild promise when you actually think about
It
it.
really is. But I mean, in our modern, hyper-optimized world, we sort of expect medical shortcuts for everything, like
Yeah, absolutely.
if you have a headache, you swallow a pill. If you see a wrinkle, you just freeze it with Botox. And now, that exact same expectation is being aggressively marketed to our sex slaves.
It is, and it's a really profound shift in how we approach human intimacy, I think. We are, like, actively seeking out these surgical or cosmetic quick fixes for what are incredibly complex, systemic, often deeply emotional issues.
Yeah.
And if you look at the marketing material surrounding these so-called lunchtime gynecological procedures, the promises they make are just incredibly persuasive.
They really are. And that gap between the marketing promise and the actual physiological reality is exactly what we are exploring today.
Which is so needed right now.
Yeah. So in this deep dive, we are zeroing in on one highly specific, widely advertised procedure to answer a single question. Can the widely marketed G-shot actually help you if you are struggling with low libido or a drop in sexual drive?
And to get to the bottom of that, we really have a diverse stack of sources to synthesize today.
We do, yeah.
We are comparing the glossy promotional brochures from these high-end plastic surgery and cosmetic gynecology clinics against the actual official clinical guidelines from the NHS and various medical boards.
Which is quite a contrast, to say the least.
Oh, completely. And to ground all of this, we're also heavily referencing a really rigorous journalistic investigation that was published by the San Francisco Chronicle. They actually looked into the real data, or, well, the lack thereof, behind these procedures.
Okay, let's unpack this. Because before we can even begin to understand if this shot fixes your desire to have sex, I feel like we first have to understand the actual physical hardware it is modifying.
Right, the anatomy.
Yeah. And when I started digging into the sources, I realized the whole concept of a shot for this area is actually relatively new, even if, the anatomy itself isn't.
That's exactly right. I mean, to understand the G-shot, you really have to look at the history of the G-spot itself first.
Right.
So it was first identified in the medical literature way back in 1950 by this German gynecologist named Dr. Ernst Grafenberg.
Hence the G.
Exactly, yeah. And he didn't discover a new organ or anything. He simply described a highly sensitive erogenous zone on the anterior wall of the vagina, right along the urethra.
Okay.
The actual term G-spot was coined decades later, like in the 1980s, as a nod to his research.
Mm-hmm.
But the G-shot procedure, like the physical injection to that space, is a much more recent invention.
Which surprised me.
Yeah, it was actually trademarked in 2005 by a Los Angeles-based gynecologist and plastic surgeon, Dr. David Matlock.
And I looked into Dr. Matlock's trademarked kits because I was fully expecting to find, some complex proprietary hormone blend in there.
Oh, sure. Some magic formula.
Right, or some groundbreaking neurostimulant in the syringe, but it's literally just hyaluronic acid or collagen.
Yep, just standard filler.
I mean, they are injecting the exact same dermal filler people use to plump their lips or fill in their cheekbones.
Essentially, yes. The entire procedure relies entirely on the mechanics of a spatial filler.
It's so crazy to me.
It is. So the doctor locates the sensitive area, which, sits about 1 to 2 inches inside the anterior vaginal wall.
Mm-hmm.
They apply a local anesthetic, and then they use that daunting 3.5-inch needle you mentioned.
Oh, just the thought of it.
I know, right?
Uh-oh.
They use that to inject the hyaluronic acid. And hyaluronic acid, it works by instantly binding with water molecules in the surrounding tissue.
So it just swells up?
Exactly. The clinical goal is to physically plump that specific area up to about the size of a quarter.
It sounds like putting a specific target on a raised pedestal. You're just physically plumping up the cushion so it's easier to hit?
Yes, that is a great way to visualize it.
Yeah.
What's fascinating here is that this is a purely mechanical, anatomical adjustment.
Right, it's just physical.
Exactly. And let's really emphasize what the filler does not do. It doesn't change your circulating hormones.
No.
It doesn't rewire the dopamine receptors in your brain, and it certainly doesn't lower your daily stress levels. It strictly increases the physical prominence and surface area of that specific zone.
which feels like a huge distinction to make.
It is a critical biological distinction.
Mhm.
We really have to separate local physical sensation from central mental arousal today.
And that distinction, I think, exposes a massive blind spot in how these clinics are actually selling the procedure.
Oh, absolutely.
Because I read the marketing materials and they promise things like reinvigorated sex lives and, more passion.
Yeah, big promises.
But since the G-shot is just a mechanical plumping of tissue, like we just said, how do we bridge that gap? Like, does a bigger physical target actually translate to a higher mental sex drive?
Biologically speaking, no, it really does not.
Yeah, that makes sense.
And to understand why, we have to look at how the medical community actually defines and treats low libido. Because in clinical terms, a persistent lack of interest in sex is referred to as hypoactive sexual desire disorder, or HSDD.
HSDD.
But there is a really vital caveat in that diagnosis. It is only considered a disorder if it causes the patient personal distress.
Oh, wait, really?
Yes, if your libido drops and you are perfectly fine with it, you do not have a medical condition. You only have HSDD if the lack of desire is actively upsetting to you.
Wow, okay, that is a huge nuance. And when I looked at the NHS guidelines, they list a massive spectrum of reasons why someone might experience that distressing drop in desire.
It's a very long list.
It really is. We are talking about severe chronic stress, anxiety, depression, relationship resentment.
All the heavy hitters.
Exactly. And then you have all the biological factors too. Extreme fatigue, the sharp drop in estrogen and testosterone during perimenopause and menopause, and crucially, the side effects of medications.
Yes, that is a big one.
The sources specifically highlight SSRI antidepressants as a major libido killer.
They do. And let's actually break down exactly why SSRIs do that, because it perfectly illustrates that difference between physical hardware and mental desire.
Okay, yeah, let's get into it.
So SSRI stands for selective serotonin reuptake inhibitor. These medications work by keeping more serotonin active in your brain, which is great because it stabilizes your mood and helps pull you out of a depressive state.
Right.
But the brain is a really delicate seesaw.
Mm.
When serotonin goes up, it almost always dampens the activity of dopamine.
And dopamine is the reward chemical.
Exactly.
It's the hormone that makes you actually crave things, whether that's like a slice of chocolate cake or physical intimacy.
You nailed it. Dopamine drives anticipation and desire. So if your medication is actively suppressing your dopamine pathways, you will not feel the urge to initiate sex, regardless of what your physical anatomy looks like.
It just won't happen.
Right, because human sexual desire is a biopsychosocial phenomenon. It requires your biology, your psychology, and your social environment to all be aligned.
Which just makes the G-shot marketing feel so misleading, honestly.
Very much so.
Because I was reading brochures that heavily target women in their late 30s and 40s who, feel like they've lost their spark.
Right, hitting exactly on those insecurities.
Yeah. But if someone's low libido is caused by exhaustion, stress, or antidepressants, how is a plumper G-spot going to magically make them want to have sex? Isn't that like installing a much louder doorbell when nobody actually wants to come over?
That is a brilliant way to frame it.
Yeah.
Seriously, the loudest doorbell in the world won't make a difference if you are just too exhausted to get off the couch and open the door.
Right.
Treating physical sensation only indirectly helps libido if the lack of desire stems strictly from sex being physically unrewarding.
Okay. Explain that a bit more.
Well, for example, if a patient avoids intimacy because she finds it physically difficult to reach a climax, and that specific frustration has sort of killed her drive over time, then making the physical act easier might remove the hurdle.
Okay, that makes sense.
But if the root cause is systemic, emotional, or hormonal, a shot of hyaluronic acid is just not going to fix the underlying deficit.
The door is still shut, basically.
Exactly.
But that massive gap between the biological reality of low libido and the promises made by these clinics, it raises a huge red flag.
A giant red flag.
If the shot doesn't fix the systemic root of the problem for the vast majority of people, why are these clinics virtually guaranteeing a reinvigorated sex life to these exhausted, stressed out patients?
It's a great question.
Are they backing this up with rigorous clinical data at all?
They absolutely are not. And honestly, the medical establishment is pushing back really hard on this.
I would hope so.
Yeah, the American College of Obstetricians and Gynecologists, which is known as ACOG, they've issued strong statements warning against these procedures.
Good.
Their official stance is that there is no valid medical indication for the G-shot, period. And there is no rigorous peer-reviewed medical evidence proving its efficacy or its long-term safety.
Wow. And on top of that, the FDA has never actually approved hyaluronic acid to be injected into the vaginal wall.
Not once.
The sources are super clear that this is entirely an off-label use. Like, they approve the filler to smooth out smile lines, not to cure sexual dysfunction.
Exactly. The lack of clinical trials is a major, major point of contention in the San Francisco Chronicle's investigation.
Yeah, that article was eye-opening.
It really was. When they looked into Dr. Matlock, the inventor of the procedure we talked about earlier, they found that his big claims of an 85% success rate were actually based on a pilot study at just 20 people.
Wait, 20 people?
Yes, just 20.
You cannot claim a medical breakthrough on a sample size of 20 people. I mean, I know high school science fairs with more rigorous sample sizes than that.
Oh, I know, and it gets even more alarming.
Oh.
He refused to publish this 20-person study for peer review, which means no independent scientist could even verify his methodology.
Unbelievable.
Furthermore, he explicitly refused to conduct a double-blind, placebo-controlled trial.
Why would he refuse that?
Well, his defense for not using a placebo was that the patients would supposedly instantly know if they received a fake injection because they wouldn't feel the physical bump of the filler.
Here's where it gets really interesting. If there are no peer-reviewed double-blind studies, couldn't a nearly $2,000 injection just be an incredibly expensive placebo effect?
Oh, absolutely.
I mean, think about the scenario. You pay $1,850. You go into this luxurious, high-end clinic. A doctor in a white coat sits down, validates your frustrations, and confidently tells you that this syringe holds the secret to the best sex of your life.
Right. It's a very convincing setup.
Your brain is incredibly powerful. The expectation alone sort of creates the reality, right?
You've just hit on one of the most powerful phenomena in sexual research. This raises an important question because the placebo effect isn't just, in your head. It is a deeply physiological response.
Yeah, explain the biology of that.
Let's look at what you just described. When a patient feels heard, validated, and genuinely believes a cure has been administered, their body's production of cortisol, which is the primary stress hormone, it just plummets.
And chronic stress is one of the biggest libido killers mentioned in the NHS guidelines.
Exactly. When cortisol drops, it allows the parasympathetic nervous system to take over.
That's the rest and digest one, right?
Yes, that is your rest and digest system, and it completely governs human arousal. You simply cannot become physically aroused if your sympathetic nervous system, your fight or flight mode, is running the show.
Which makes total sense.
So by paying the money and feeling attended to, the patient inadvertently lowers their own stress levels, which allows their natural arousal pathways to finally open up. They experience better sex, but it's entirely independent of the hyaluronic acid.
Wow. But this raises an important question, though. If these clinics are essentially just selling a very expensive placebo to women who are really just stressed out and exhausted, are we even treating a real medical deficit, or are we just capitalizing on culturally induced insecurities?
Yeah, and that exact ethical debate is being spearheaded right now by researchers like Dr. Lenore Tiefer.
Right.
She's a psychiatrist at the NYU School of Medicine who co-founded something called the New View campaign. Her whole organization basically pushes back against the medicalization of female sexuality.
Which is so important.
It is. She argues that we live in this post-Viagra era that has created these highly unrealistic expectations. Our culture basically demands that stellar, effortless, frequent sex should just be the absolute norm, regardless of what else is happening in your life.
And when you inevitably fail to meet that completely impossible standard, because, you're human,
Exactly.
the industry steps in and tells you it's a pathology that needs to be surgically fixed.
Precisely. It pathologizes completely normal statistical variances, like libidos naturally ebb and flow over a lifetime. Climax sometimes takes concerted effort. That isn't a disease. That's literally just being human.
The San Francisco Chronicle article featured a case study that illustrated this so perfectly.
Oh, the 22-year-old student.
Yes. They interviewed this 22-year-old student who was also a young mother.
Right.
She was exhausted at the end of every single day, and she felt deeply frustrated that sex with her partner suddenly required so much mental concentration.
Understandably so.
Right. But instead of recognizing that she was carrying this massive cognitive load and honestly just needed childcare and a nap, she thought her body was fundamentally broken, and she started looking into cosmetic surgery.
It is just a tragic misdiagnosis of the real problem. When we reduce human desire down to a literal anatomical target, we entirely discount the brain. which is undeniably the most powerful sexual organ in the human body.
So true. So, if the G-shot is this highly debated off-label spatial filler that, as we just discussed, relies heavily on a potential placebo effect, what do the medical sources actually recommend for a listener who is genuinely struggling with low sexual drive?
When you talk about real solutions.
Exactly. If we step away from the cosmetic quick fixes, what are the actual holistic evidence-based alternatives?
Well, the sources outline several distinct evidence-based pathways. But the right path obviously depends entirely on diagnosing the true root cause of the distress first.
Right.
However, before we look at systemic fixes, we should probably briefly clear up a major point of confusion in this cosmetic space, which is the difference between the G-shot and the O-shot.
Oh, right, because I saw the O-shot plastered all over the exact same clinic websites, and honestly, the marketing language is almost identical.
It really is, yeah.
But biologically, they are completely different mechanisms, right?
Very different.
Yeah.
As we've established, the G-shot is just a spatial filler using hyaluronic acid to create a physical cushion. But the O-shot, which stands for the orgasm shot, utilizes platelet-rich plasma, or PRP.
PRP,
Right.
okay.
In this procedure, they actually draw your own blood, spin it down in a centrifuge to isolate the concentrated platelets and growth factors, and then they inject that plasma back into the vaginal tissue.
And the goal there isn't just to add volume, right? Like, the sources claim PRP actually stimulates tissue regeneration.
Yes, exactly.
Yep.
The biological mechanism of PRP is angiogenesis, which basically means the creation of new blood vessels, along with neurogenesis, which is the growth of new nerve endings.
Interesting.
Because it supposedly rejuvenates the actual health of the tissue over time. Sources note it is often used to treat stress urinary incontinence, like leaking when you laugh or sneeze, as well as severe vaginal dryness.
Okay, but even with the O-shot, you're still just addressing the local physical hardware. Like, if the problem is systemic, if you have absolutely zero mental desire to initiate sex in the first place, regenerating the local tissue still isn't addressing the brain. So what are the actual systemic interventions?
Right, let's get into the systemic stuff. If the underlying issue is a true biochemical drop in libido, particularly related to perimenopause or menopause, the gold standard medical intervention is hormone replacement therapy, or HRT.
Okay, HRT.
Because as your natural estrogen drops, the vaginal tissues naturally lose their elasticity and natural lubrication. But more importantly, as your testosterone drops, your neurological drive for sex diminishes.
It actually really surprised me to see the NHS specifically recommending testosterone for women.
Really?
Yeah, I feel like we are so culturally conditioned to think of that strictly as a male hormone.
Oh, sure, I get that.
Yeah.
But women and rely on testosterone too, just in smaller amounts.
Right.
It is a massive driver of energy, mood, and sexual desire for everyone. The NHS guidelines actually highlight that if standard estrogen HRT doesn't fully restore a patient's sex drive, a specialist might prescribe a low-dose testosterone gel just to get that neurological craving back online.
Wow. And what if the lack of desire is stemming from like a physical pain loop? Because the sources also discuss vaginal atrophy, where the tissue naturally thins out as we age, making sex incredibly painful.
Yes.
If a patient is avoiding sex just because it hurts, how do we fix the tissue without resorting to those off-label fillers?
Well, there are highly effective non-surgical medical interventions for atrophy that actually address the cellular health of the tissue.
Like what?
For example, the sources outline specific laser treatments, like the Diva laser. This device uses precisely calibrated light energy to create thousands of microscopic thermal injuries in the vaginal wall.
Honestly, that sounds super intense.
It sounds a bit scary, I know. But the mechanism is fascinating. By creating those microwounds, it basically tricks the body's natural immune system into rushing to the area to heal it.
Ah, okay.
Exactly. The body responds to those microinjuries by generating a massive rush of fresh collagen and elastin. So it's structurally rebuilding and thickening the thinned-out wall from the inside out, naturally.
That is amazing.
And there are also needle-free at-home treatments, like the CO2 Lift V. This is a form of carboxytherapy.
Okay, how does that work?
You basically apply a gel that delivers carbon dioxide directly to the tissue. This triggers something called the Bohr effect, forcing your red blood cells to rapidly release oxygen to the area.
Wow.
Yeah, and that promotes intense natural cellular healing and restores natural lubrication.
Okay, so there are real cellular level physical treatments, but we absolutely cannot ignore the psychological side of the equation either.
Never.
Like, if you are on SSRIs, you might just need to have a conversation with your psychiatrist about adjusting the dosage or maybe trying a completely different class of medication.
Exactly.
Or if your low libido is stemming from buried relationship resentment, the best intervention isn't a laser at all, it's couples counseling.
Spot on.
And if you are crippled by performance anxiety, the sources highly recommend cognitive behavioral therapy, or CBT, to really help reframe the neural pathways that are linking sex to stress.
Yes, CBT can be incredibly effective.
So, to put it simply, the G-shot is like applying a temporary cosmetic filter to a photo, while treatments like HRT, treating atrophy, or doing therapy are like taking the camera apart and actually fixing the lens and the wiring.
That's a great summary. And if we connect this to the bigger picture, it just reinforces the fundamental truth that human sexuality cannot be isolated into a single injectable coordinate on a map.
No, it really can't.
You simply cannot separate a person's physical anatomy from the complex, emotional, hormonal, and relational context of their everyday life. When the medical cosmetic industry tries to reduce human desire down to a mechanical button that just needs to be, plumped up and pushed harder, they do a massive disservice to how beautifully complex and interconnected the human body actually is.
I completely agree. So what does this all mean?
Yeah.
Well, if you're listening to this deep dive right now and you've been quietly wondering why your libido isn't quite what it used to be, the most important takeaway we can offer is just to give yourself some grace.
Absolutely.
Understand that your body is not a machine with a broken switch. It is a complex, reactive ecosystem. The G-shot is just a temporary anatomical amplification. I mean, it might increase physical friction during penetration, and if that's exactly what you're looking for, then hey, it might serve a purpose.
Sure.
But it is absolutely not a magic bullet for systemic low libido.
Not at all. The crucial first step is to identify your real underlying hurdles. Are they physical pain, hormonal depletion, maybe medication side effects, or just emotional exhaustion? Having a candid, comprehensive conversation with a medical professional who looks at your entire biopsychosocial health history is just essential before buying into any heavily marketed cosmetic shortcut.
Because true desire is just infinitely more complex than a single spot of tissue.
It really is.
But, studying these mechanical shortcuts does make you wonder about where the future of sexual medicine is actually heading.
Oh, for sure.
Because we are currently so obsessed with physically hacking our anatomy with needles and lasers and fillers. But if human libido is ultimately governed by the brain-like, if it's really all about dopamine and serotonin and the parasympathetic nervous system, what happens in the future when we finally map the exact neurological pathways of desire?
Oh, wow, that's a wild thought.
Right, like will we eventually just skip the physical anatomical injections entirely and start seeing neural implants or digital tweaks to artificially generate libido on command?
It's definitely possible.
And if we do reach a point where desire is just, I don't know, an app-controlled switch we flip in our brains,
Right.
what happens to the natural, organic, emotional connection between partners? Something to think about.